Why the sick has advantage over PK? Because it's less invasive, smaller surgical incisions, no corneal sutures, fast visual recovery, less risk of sight-threatening complications. The eye is more strong, not fragile with the graft, less risk of rejection, short post-operative care. We use steroid, but still not same like we are using with penetrating keratoplasty. The sick, easier learning curve than the MEC. Regarding the sick challenges or the problems, the visual rehabilitation is less than the DMIC. Okay. The interface, it could be decentered, it could be dislocated, it could be detached. Okay. One of the side effects, drop in the donor endothelial cell density in the early post-operative period. Okay. If the graft is detached, we return it back. And we know by anterior segment OCT. This photo shows here epithelial ingress. This is the venting incision, and there is epithelial ingress here. Okay. This again repeated. Same again, grafted detachment. It could be glaucoma. Glaucoma, I am going to mention again. It could be, but less rejection. Regarding the penetrating keratoplasty, I'm not going to mention everything in detail, but I will highlight here that some patients have better prognosis than other patients. For example, keratoconus and lattice and granular has the excellent prognosis. And then bullous keratopathy and Fuchs dystrophy and macular dystrophy, and also active bacterial keratitis. That's why recently the cornea specialists encourage early surgical intervention and vascularized cornea. Starting from these, the diagnosis is guarded to bad. Fungal keratitis, congenital glaucoma, and the children in general. Okay. And very severe bad prognosis, keratoconjunctivitis thick. What are the factors control this? The size of the graft, the age of the patient, the blood group, position of the graft, if there is any exposed sutures, if there is vascularization, if there is any glaucoma previously, or any ocular surface disease, or previous also iritis. Two or three difficult cases, children, first case. Second case, glaucoma patients. So what will happen in the glaucoma patients? Usually, they're high risk of graft dislocation and rejection. So there is a trick from one corneal specialist advice that we close the tube temporal with a suture and we make a smaller graft. Okay. Regarding aphakia, also this is a difficult patient because what will happen in aphakia? So the air bubble will go back in the posterior chamber and will cause pupillary block. So this is again some tricks. We can do some little viscoelastic in the pupil. Okay. And we will do suture at the superior rim of the donor graft to the recipient cornea. So make sure that the graft will not move. This is in the sick. Okay. What are the problems of large grafts? Rejection, glaucoma, and large epithelial defect. I hope you are following and not find this boring. What are the complications? Hypotony or glaucoma, persistent epithelial defect, endophthalmitis, all these early post-operative. Late post-operative, rejection, keratitis, recurrence, astigmatism. This syndrome has iris atrophy and dilated pupil following keratoplasty. Late endothelial failure and glaucoma. Glaucoma, it can happen early and late. Other complications seem like other surgery. Graft failure, it could be early or late. Okay. Early due to problem in the graft. Okay. Or recurrence of the disease or glaucoma. Late due to rejection, which is immunological reaction or glaucoma or infection, any of the other complications I'm going to tell now. So anyone can comment on this?
This is a graft infiltrate, ma'am, graft infection. So the eye is congested. The graft is central graft, which the central part and superior part of the cornea appears clear, but there is a infiltrate at around 7 o'clock junction involving the graft and the graft host junction. And there is peripheral vascularization onto the host cornea, not extending onto the graft. The sutures are intermittent sutures. There appears to be no suture infiltrate. And coming to the anterior chamber, I can see a peripheral iridectomy at 11 o'clock position. The pupil is eccentrically dilated. Probably the patient is pseudophakic. The image is not very clear. So this is a case of graft infection.
Okay, thank you, Dr. Hasika. Anyone?
There is epithelial defect also.
Yeah. Anyone has a comment? Okay, the sutures are not uniform. Some tight, some short, some long, and the wound looks not coacted. The pupil is drawn to this infection. Maybe there is anterior synechia, peripheral anterior synechia. Okay. The eye is injected. Graft rejection. We have three types of graft rejection, either epithelial or stromal or endothelial. Epithelial, we find epithelial demarcation line. Stromal or subepithelial, we find some whitish dots, numerous white infiltrates, Krashmar spots. Endothelial, we will find corneal edema, caries, keratic precipitates, Hodadost line. Okay. Seem like uveitis with increased high intraocular pressure. What is the management here? Topical steroid. Again, here topical steroid. Here topical steroid. We could also give subconj or systemic steroids as well as cycloplegia. What are the risk factors for injection? The age, size of graft, position of graft, if there is exposed sutures, if there is vascularization. So this is the stromal Krashmar dots. This the endothelial rejection. This is the Hodadost line, and there is caries, okay, and the graft is hazy and edematous, and there is vascularization. The eye is angry, okay. If we find the caries in a graft, This graft could be from rejection or from viral infection. Okay. So this table to differentiate between the key beads in case of rejection or the key beads in case of viral infection. The key beads in case of rejection, we will find the Khudedust line, we will find the intraocular pressure is not high. But in trabeculitis or viral infections, we will find high IOP. Okay. We will find the endothelium looks coin-shaped. We might find the dendritic or stromal keratitis. We will find both the graft and the host cornea has cavities. Same point like Dr. Ahmed mentioned. Okay, this one rejection also. Can anyone comment on this?
Ma'am, shall I try, ma'am?
Yeah, sure.
The first image A is endothelial rejection, ma'am. The eye is inflamed. There is a corridor's line with capies on the endothelium. The inferior half of the cornea appears hazy and edematous. So first case is endothelial rejection. The second case, it looks.
But
the second image.
you should comment on the sutures. You should comment on the interface.
Okay, ma'am. The sutures are intact. They're intermittent sutures. There are few infiltrates on the suture infiltrates, ma'am.
Yeah.
They look like sterile suture infiltrates for me.
Yeah. The interface.
And the interface. The interface I can't comment, ma'am. How can I comment on interface in this image, ma'am?
You can comment by positive or negative. Do you see any gapping? Can you appreciate if this is penetrating or?
It looks like penetrating keratoplasty for me. Optical, I mean full thickness keratoplasty.
Yeah, and
am I right, ma'am?
as you mentioned already, it's a hazy and showing
edematous.
Yeah.
Yes, ma'am.
Okay.
Okay, and shall I come to the second image?
Yeah, sure.
So the second image shows a central graft with corneal infiltrate involving almost entire graft, ma'am. And the host cornea appears normal. The sutures, there are continuous running sutures as well as intermittent sutures. There is a suture infiltrate at even at around 5 o'clock position, and also at 7 o'clock position, ma'am. Yes, ma'am, that area. So it is a graft infection.
Yeah.
Anything I missed, ma'am? The rest of anterior segment details are not appreciable. Again, coming to the interface, it could be a full thickness keratoplasty again.
Yeah.
Third image, C. This is a failed desect, ma'am. My opinion, because I can see tunnel sutures on the temporal tunnel sutures as well as the side port sutures. The eye is relatively quite not very angry looking, and the central graft, I mean the lenticule appears edematous, and the entire central cornea is hazy. I can even see some descemet membrane folds. Then the patient is pseudophakic, ma'am. I can even see a peripheral iridotomy at 1 o'clock position.
So this is what is your provisional diagnosis?
A failed desect, ma'am. A failed graft, desect graft. This is my opinion.
Thank you, Dr. Hasika. Does anyone
coming to D image, it's is it PCL?
Does anyone has any other comment? Okay, proceed, Dr. Hasika.
And coming to D image, that's the anterior segment photograph showing bandage contact lens, ma'am, first thing. And there is a stripping of there is rolling of inward rolling of Descemet's membrane.
This is
see a
anterior segment.
ASOCT picture of cornea.
Yeah.
Showing I mean the graft host junction is intact, ma'am. I can see that, but there is a yes, ma'am, and there is a rolling of Descemet's membrane inwards, and the upper line, is it the bandage contact lens, ma'am? That on the epithelium, over the epithelium. Yes, ma'am. That
I'm not sure.
It could be a bandage contact lens, right? Because there is some space in between.
Yeah.
Yes.
Thank you, Dr. Hasika.
Yes, ma'am.
So this again mild rejection. Okay. This one again rejection. Okay. The graft is hazy and edematous. Okay. Rejection again. This one infection. This one fibrous downgrowth here and here. What is the difference between penetrating keratoplasty and the DALC? Regarding the size of the graft, it should be oversized. Here in the DALC, it should be same size. Why? Because more endothelial cells in reverse, because the graft will be convex to prevent peripheral anterior synechia and to make the wound sealed tightly. DALC, we should select the same size to avoid a ridge at the host graft junction. Okay, so healing occurs properly and no persistent epithelial defect. The sutures, we can choose either intermittent, here continuous. Interrupted is better because in case of infection. Okay, continuous, it's better for astigmatism. This algorithm management of both keratoplasty infections. Okay, this is the decision resurgery. Okay, I'm not going to mention it, but in case we are corneal specialists, we might look at it. Okay. Regarding glaucoma in a case post keratoplasty, in a case of penetrating keratoplasty or the MEC or the SAC, it could be early, it could be late. Early onset due to retained viscoelastic. It could be due to the suture technique. If I took tight sutures, long bites, okay. If I select the graft size, same size, so I will do crowding at the angle, okay. If I did crowding at the angle, so I will do angle closure glaucoma, okay, same like this picture. One of the possible reasons also inflammation, okay. Late onset glaucoma, it could be steroid induced, it could be persistent inflammation. That is regarding penetrating keratoplasty. In the MEC or the SEC, it could be similar, but regarding the reason of steroid, it's less possible because we are not using steroid same period like penetrating, but we have here one specific cause, air bubble induced angle closure pupillary block. So the air bubble will We'll do the pupillary block as shown here. Okay. Also same reasons like the viscoelastic and so. Here no sutures. Okay, so we have the air bubble. Late onset, it could be also steroid, but less common. It could be peripheral anterior synechiae or inflammation. This some cases quickly. I don't want to keep you. Okay, and also our meeting will end soon. I put only these cases for a revision for commenting. Okay. This patient before surgery had stromal scar. This after surgery. Okay. What was the procedure? Deep lamellar keratoplasty. This patient acantha amoeba, keratitis. This one after post-operative. This one after some time. Okay, 1 year post-operative. This one viral herpes simplex. Okay. This one pre-operative. Okay, this 1 year post-operative. This one keratoglobus. Okay, this keratoglobus. This is after surgery. Okay. And I finish my presentation if Dr. Ahmed or any other candidate want to comment.